All right, so as I was saying, I'm Matt Wicklund. I'm a neuromuscular specialist. I got trained by the last guy that gave you a talk, and I won't tell you how many years ago that was, but it was the last millennium, if that gives you any. So I do want to thank the Jane Foundation for allowing me to come and speak, and I did have, I always have to read this, but I just want to start with just a little teaser. So in 2012, I remember a slide that was really exciting to me. It said, "It's a great time to be a mouse with muscular dystrophy." And the reason that was a great slide is because we could cure a lot of mice that we gave muscular dystrophy. So that was a good thing. So fast forward to 2014. This is the first time I ever heard this. And this really took a room of us. So at a conference, there's a guy that said, "Hey, you need to start remodeling your clinics from diagnose and supportive care into treatment clinics because there are a number of different agents that are in phase 1, phase 2, and phase 3 trials moving forward." So he said in the next year or two, you're probably going to need to have treatment clinics. And so that's a whole different way for us to do what we're going to do. And that kind of goes with what Dr. Mendel and Doug talked about earlier. So now let's see if I can do this. Here we go. This is what I wanted to talk to you about, and this is what I was told that would be good for you to hear about, and hopefully when I talked to you all last night, I heard some of this also. So first is, if I can help you know what you have, I think that's going to be important to you, because not everybody's the same. We talked about that at lunch. Not all the people in this room look the same. And then maybe why is it that the diagnosis was hard for your doctors to make? So I'm going to go on the side of the other doctors that didn't quite make your diagnosis, like you walk in and then they just walk out and say, "Oh, I know what you have." We have certain disorders we can do that. So we'll do it through sort of 5 questions. You can see those questions on there, and we'll kind of walk through that. I know all of you have a genetic diagnosis, but again, not all of you are exactly the same. I'm going to take a lot of this from, in October of 2014, there was a guideline that was published that had to do with the diagnosis and treatment of the limb-girdle muscular dystrophies. And so this looked at over 3,000 articles that have been published from 1987 through 2013. And we looked at all of those articles, and we culled it down to the ones that had pertinent information related to the limb-girdle muscular dystrophies. So I'm going to talk through, and first of all, I'm going to use that word Dysferlinopathy. And the reason is, whether you have LGMD2B or Miyoshi or some other, it's sort of similar. It's all from the same gene. So you'll hear me say Dysferlinopathy, not just 2B or Miyoshi, except for when I describe particular phenotypes such as, and so a phenotype is what are the physical characteristics that you display. And so there is a limb-girdle pattern, and when you look in the literature, roughly half of all the cases presented predominantly with a limb-girdle pattern, and roughly half of the cases presented with, let's see if I can do this here. So roughly half the cases presented with a distal phenotype, so a distal pattern. But there were other ways that you could present, and those included all these less common forms. And Brad brought that out with a question he brought out. We don't know the full phenotypic spectrum. We don't know what everybody that has a dysferlinopathy looks like. And it's interesting that even though you might have a brother or sister, often you look a lot alike, but you can look somewhat disparate in your age of onset. Your rate of progression can be different. So most of you all have onset in the 2nd or 3rd decade, so usually in the teens or the 20s. It can be older, it can be younger, and it can be as early as 0 all the way up to 73 years of age. Most have some distal involvement. So this is a good example here. Again, you can see the calves are relatively thin on this gentleman here. Calf atrophy is common. Asymmetries are also common, side-to-side differences. And then patients do not have their shoulder blades stick out. They don't have trouble swallowing. They don't have problems with changes in their voice. They tend not to have joint contractures, so they can straighten their arms out. And they tend not to have cardiac involvement. Now, some folks can have pulmonary function. I heard about that starts diminishing, but that usually is later, and rarely is it symptomatic, but it can be. So this is just an example of the distal involvement. Interestingly, the distal involvement can involve the front part of the calf, or it can involve the back part of the calf. And this is an MRI, and this MRI shows this is the muscle that's in the front part of the calf, and here's in the back part. And so this person presented with a foot drop. So this is a person trying to actually step and hold their foot up, and they just can't do so. So that's called distal anterior tibial myopathy, which is a type of a dysferlinopathy. And then over here, you can see that these muscles are fairly well maintained, and yet the muscles in the back, those are the big muscles of the calf back here, the gastroc muscles, and those are wasted in this person, so they're atrophied, and that person presented with trouble standing on their tiptoes. So you can present with one or both of those. Dr. Mendel's group also pointed out that it's not always the case that you have calf atrophy. You can start with enlargement of your calves early in the course, and then they can get somewhat atrophied later. And then also, muscles that can be sort of enlarged are the deltoid muscle. And you can look especially here, deltoid muscle is relatively large, and yet you have very small biceps. So muscles right next to each other can be quite different. And so these are different patterns that patients with dysferlinopathies can have. So this is from India. A large number of patients were reported out of India that have this, and I don't know in the room, we'd have to have everybody take their pants off, which we will not do. And this is a description that they found in roughly 2/3 of the cases where when the thighs were involved, it involved the distal most, so towards the knee, and then the proximal most part of the quadriceps. So it left this middle portion relatively spared, and you got this diamond on quadriceps, which I think is probably best seen in this person right here. And you can also see it, these are MRIs that show the very same thing. All right, so I've said that patients are not really the same that have dysferlinopathies, but now I'm going to go back and say, well, yeah, they are. And so these are MRIs of patients that have limb-girdle muscular dystrophy type 2B and Miyoshi myopathy. So they present either proximally predominant or more distally. And if you look at these are cross sections of the thigh. So this is the quadriceps up here, and down here you have the hamstrings, and over medially here you have the muscles that pull your legs together, the adductors. They pull the legs together. And what you can see is whether you have Miyoshi or 2B, you tend to initially affect some of the adductor muscles. They've highlighted it here. A little further on, you tend to affect more of the adductor muscles and some of the hamstring muscles. A little further on, you get involvement of the quadriceps, and you can see these are not quite exactly the same between the two, but the pattern is almost exactly the same. And in the end stage, if somebody has quite a bit of atrophy, you spare this muscle right here, and that's it. You're simply sparing one muscle. So going to the calf, you find the very same thing. Even though somebody presents with distal involvement, so Miyoshi myopathy, unable to stand on their tiptoes, their hips seem pretty good. But if you actually look at the rate of progression in 2B, you see the medial aspect of the calf. So that's just the gastroc, the big muscle here, the medial part that is affected, and it's affected in Miyoshi. You then see that the majority of the gastrocnemius muscle is affected, and then you see more of the gastrocnemius muscle, and then in the end, you can see in both of these that you have all of the calf muscle, except you predominantly spare this one muscle that actually turns your foot inward. So it's the inverter, which is tibialis posterior. So I just told you you don't look alike, but now you look all exactly the same if we do an MRI. Something like that, okay. I want to talk a little bit about dysferlin itself and what does it do. So this is a little cartoon that shows the inside of a muscle fiber. Here's the muscle membrane, and here's outside of a muscle fiber. And so when you look at stains, you're going to tend to see that dysferlin sits right along the muscle membrane. So we talked about what does dysferlin do. So early on in 2003, there was a very nice study, and you've seen the actual animated that Dr. Mendel showed you of a little micro laser in a muscle fiber. And you make a little rent in it. And then these little green figurines here are associated with little vesicles. That's the dysferlin. And as calcium floods in, you have membrane repair. But dysferlin's more complicated than that, and it's probably involved in a number of other things depending on which lab is involved in it. It has to do with mitochondrial function, has to do with T-tubule function. So there are a number of things that it has to do with. So all of you know that your muscle enzyme levels at some point were elevated, sometimes markedly. And when we look at this in a large number, it's usually anywhere between 1,000 and 30,000 for your creatine kinase level. As time goes on, it does go down, but generally it's quite high. When you look at muscle biopsies, you're going to see inflammation, and the inflammation looks like you see here. And that inflammation is usually in roughly half to 2/3 of the biopsies that you'll see that. Last night, I met several people, and yes, they had polymyositis, and guess what? It didn't respond to therapy. Yeah, so that's pretty common. And actually, there was a study that showed that deflazacort was not effective, so that's a corticosteroid. And the other thing on biopsies that we'll see is amyloid, and amyloid can be seen in up to about 20% of patients. Amyloid is simply a misfolded protein that we can see with certain types of imaging and certain types of staining on a muscle biopsy. Once again, I'm going to point out inflammation. This is polymyositis, and so you can see these are muscle fibers here. These are inflammatory cells, so these are lymphocytes. And then you can see the same is also true where you see rests of inflammation in between the muscle fibers. And interestingly, you also see it in Duchenne muscular dystrophy. But inflammation is not an uncommon thing in muscular dystrophies, certainly in Dysferlin. So we talked about that Dysferlin usually lives at the surface of the muscle fibers. And so this is a person that has normal Dysferlin staining. But in most patients, you're going to see on a biopsy this, which is you don't have any Dysferlin staining. But not everybody looks that way on a biopsy. So sometimes you wind up with diminished Dysferlin staining. And then there are biopsies that show lack of staining of the muscle membrane, but there's increased staining in the sarcoplasm, so inside the muscle fiber. And what that is, it makes it more confusing, and that may have to do with the different ways in which Dysferlin acts and the different ways in which different mutations affect Dysferlin. And to make it more challenging for your doctors, there are a lot of other disorders that also can have abnormal Dysferlin staining. So just because you have abnormal Dysferlin staining doesn't necessarily mean that you're going to have a Dysferlinopathy. If it's absent, most likely you're going to have a Dysferlinopathy. All right. You're all diagnosed. There are different ways to do it. There were a lot of folks that for quite a number of years had Western blot, which is simply they grind up your muscle and see how much protein you have. That's a good way to do it. But it really doesn't get at whether or not you have a mutation in Dysferlin. So the key is you have to do either gene sequencing, some sort of next generation sequencing, or exome genome sequencing. Some way to figure out, do you have a mutation in Dysferlin? All right. So what else looks like Dysferlinopathies? This is where I get to come to the rescue of all the other doctors that didn't quite make the diagnosis in the very first place. So here we go. So Dr. Mendel sort of showed you this. When we started in our guideline, we figured, it's a lot to do. We have 27 different genes we need to sort out and figure out for this guideline. And we thought, okay, 27, that's a lot. Our colleagues that did FSHD, they had 2. Myotonic dystrophy, they had 2. Congenital muscular dystrophy, they had a lot. They had 8. Okay, all right, so we had 27. But once we got started, these people all look not too dissimilar. So these are all just people that are still ambulatory, and they all have a limb girdle pattern of weakness, but this is 2B, this is 2A, this is 1B, this is 2I, and this is Becker. And so your doctor may have a hard time distinguishing just by a single person walking in trying to say, oh, I know what you have, because sometimes it's not that easy. So when we wrote the guideline, there are a number of disorders like Dysferlin that can present with a limb girdle pattern or a distal pattern. So in the guideline, we said, oh, we have to include 9 more genes. Well, there's a limb-girdle muscular dystrophy that also presents sometimes with what's called an Emery Dreyfus pattern. These people have relatively prominent contractures, often of the elbows or of the ankles, and that's relatively early in the course, and so we had to include these 6 genes. And then there are some of the limb-girdle muscular dystrophies that are what are called myofibrillar myopathies. That's actually a pathologic diagnosis. And we had to include those in the guidelines. So by the time we were done, yes, we didn't have what some of you initially were diagnosed with is, oh, you have limb-girdle muscular dystrophy. We had 50 plus genes that we had to analyze because they all look somewhat similar. So forgive your initial doctor that made a mistake. Okay. So I'm going to go here and just kind of recap. This is outside of a muscle fiber. This is a muscle membrane. This is the contractile apparatus of the muscle fiber itself. This is the nucleus of the muscle fiber. And if you look, wherever you see one of these little boxes, that is a limb-girdle muscular dystrophy, and it affects just about anywhere along here. And interestingly, where you see 5 right here all doing the same thing, there are now 17 different genes that do that very same problem with we call it glycosylation of alpha-dystroglycan. But the whole point is it's even bigger than we used to think. So it's a very broad category. So hopefully you've forgiven your original misdiagnosis. Plus, they didn't know as much back when you were originally misdiagnosed. All right. How common are dysferlinopathies? That's a big question. We don't know the answer to that. However, we do know some things. It probably depends a little bit on where you live. So if you live in Northern Europe, limb-girdle muscular dystrophy 2A, 2I, and 2L are very common, and 2B is not very common. If you live in Southern Europe, 2A is very common. If you live in North Africa or Asia, 2B is much more common than the other limb-girdle muscular dystrophies. If you live in South America and North America, we're polyglots. So we really have a whole bunch of things all thrown in together. But it's interesting, on the East Coast, my colleagues and I, we see more 2A than we see 2B. But my colleagues on the West Coast, they say they see more 2B than 2A. I don't fully understand that. I can tell you, though, we had the opportunity to look at roughly 500 patients with limb-girdle muscular dystrophy that had genetically confirmed muscular dystrophy from 2001 to 2010. And if you looked at all comers in the United States, the most common was 2A, but the second most common was 2B. At roughly 19% of all the patients that have limb-girdle muscular dystrophy have 2B. Now, how can it be a rare disorder or a very rare disorder if there's 19%? Well, we don't know what the total number is here. And we'll learn more about that as we go. All right, so how do we diagnose dysferlinopathies? And the reason I've got the Jane Foundation on here is because they've really made a difference in the way that we do diagnose limb-girdle muscular dystrophies and dysferlinopathies. So the way I go about trying to figure out what a patient has is I can look at patients that have fascioscapulohumeral muscular dystrophy, myotonic dystrophy, or oculopharyngeal muscular dystrophy, and they all have a distinctive sort of way that they look. And usually when you have that, you can just, actually I tell my residents for a patient that has myotonic dystrophy that has all the classic features, they get to walk in the room, shake their hand, walk out, and tell me what the diagnosis is, because you can just look at them and you know. So these are easy. We just do genetic testing, and most of the time we're going to be right. However, if you have this limb girdle pattern, it's much more difficult. Then you have to combine what does the person look like, what was the age of onset, is there a family history, what is the muscle enzyme level, and what does the EMG show, and then sometimes you can do targeted genetic testing. It is very helpful that the Jane Foundation does have this SMART algorithm, so it's the automated limb girdle muscular dystrophy, what is it, assistant? Thank you. And it really is quite helpful because it sometimes will help us ferret out with usually, what are the total number of questions? 30-some, 40-some? Yeah, it's a number of.
It's sort of, there's a second round of questions, and how many it asks depends on what you answer. So it's sort of variable. There's about 40 in all, but
That's what I thought. So with that being the case, you can use that to help guide you as to what the diagnosis might be out of those 50, 60, 70 different genes, and that's very helpful. I will say that it's important that you do other testing, not in you all, but for a doctor to try to make the diagnosis. They shouldn't miss dystrophin, and they shouldn't miss Pompe disease. All right, so patients have been enabled. This is great. Patients can go directly to the Jane Foundation website, and do their own little shorter quiz. And it has 17 questions. And then they get tested for these 35 genes. That's really kind of nice. And did we have one person, I think, that was diagnosed that way? I think so. Where is she? Yes. Absolutely. So it works, and it empowers patients to make their own diagnosis. So let's say that we don't get to the right answer as a physician. What do we do next? Should we do a muscle biopsy? That's a very good question. 3, 4, 1? Too many. Okay. So the answer to that nowadays is different, because a muscle biopsy costs $7,000 to $12,000. It's really not that much when you just do the biopsy, but all the immunostains and everything you do to it, it's pretty expensive. But insurance pays for it. But interestingly, we can now do different panels of testing for much less than that. So these panels usually cost somewhere around $2,000 to $4,000, and that gives you a distinct diagnosis. Or you can do these. The problem is exome and genome sequencing really do not pick up as much as we need. And so now we're doing more directly going to diagnosis without a muscle biopsy, simply based on the fact that you have a limb girdle pattern and doing a panel to make a diagnosis. So I'm very excited about this. So there are about 5,000 patients that received a letter saying, hey, we'll do genetic testing for you using that same 35 gene panel. And those are all patients that have limb girdle muscular dystrophy. And so we know how many patients are in this room. If we do the math, 15 to 20% theoretically are going to be Dysferlinopathies out of 5,000. That's a lot of patients that are out there. All right. Again, I like this quote. It has to do with tautological reasoning. It has to do with, it looks like this, therefore I'll test for that. I'll test for that when it looks like this, and this always looks like that. Well, now that we're doing broader looking, I think that this quote from an old English fairy tale actually serves us quite well. So whilst looking down a rabbit hole, all I saw was bunnies. But once my eyes gazed about the glen, the panoply of species I did see. I think we're going to see that Dysferlinopathies look not the same as everybody in this room. They may be slightly different, which is sort of what we've seen in some of our family studies. All right, so let's get to the big question. I heard this, I think, from almost every patient, except for the most recently diagnosed. Why should I keep going to see my doctor? And that's really a good question. A decade ago, it would have been harder for me as a physician to say, I have a really good reason you need to go every year to go see your doctor or more often, because I don't know that you could honestly say that. But I'm going to use a little letter that I used to get genetic testing approved to explain the reasons why I think you should go see a doctor. And then I'm going to end with a slide that really sort of tells you why now you should go see a doctor regularly. All right, so the first thing, the accurate diagnosis of genetic muscle diseases is important for patients, you all, your families, and for efficient and cost-effective medicine. So it's actually more efficient now to do genetic testing than a muscle biopsy to get a definitive diagnosis. So we should do this. A genetic diagnosis assists in defining the long-term prognosis, and this is mostly for delineating between 2B and other diagnoses. because some of those others do have other organ system involvement. I remember hearing last night that someone was happy they had 2B because then they didn't have all the other ones. Yeah, that's right, because they can affect your heart, etc. Now, of course, I'm not going to say that it's right that you say, ooh, 2B or no 2B. Okay, all right. Wait, Shakespeare, never mind. Okay. All right, so the precise identification of the disorder eliminates the need for repeated testing. 3 biopsies. Anybody beat 3 biopsies? Anybody go 4? How many? 4? 3? Oh, yeah. 4. Okay, we got 4. So, all right. But even more importantly, yeah. So the other thing that I think is very important, you also have to distinguish this from other treatable disorders, which I heard last night, such as inflammatory myopathies like polymyositis, where they put you on these chemotherapeutic drugs that do have adverse side effects. If you don't need it, you shouldn't be on it. Okay. We talked about this. The cost of a biopsy is actually more than the genetic testing. And although establishing it is more expensive, or is somewhat expensive up front, in the long run, it actually is much less expensive. This is a very important one. I have more patients that have limb-girdle muscular dystrophy that are very happy because once they get a diagnosis, they finally have something they can hold on to. That's very important. It provides at least a little bit of closure so they can target what they want to do. And then establishing a genetic diagnosis is crucial for counseling about decisions about future planning for families. Actually, most of the people I talk to already have kids. I think that's a reasonable thing. I like that. That's great because your kids aren't going to have it. But if you had something that was running generation to generation, you might think twice. Final reason, patients can remain engaged in their own care, and I'm going to talk about care a little bit more, and in further disease discovery, meaning knowing more. That would be called the clinical outcomes study, so COS, through regular evaluations with their neuromuscular specialist and through participation in research trials on natural history and or treatment. And that segues back to what Dr. Mendel talked about, which is he's talking 2016 is hopefully when he can get started with a gene therapy trial. So when we ended this guideline for the limb-girdle muscular dystrophies, our recommendations were that we need more large prospective long-term population-based studies. Sounds like cost to me. Studies of genotype-phenotype correlation, optimal management of other organ system involvement, evaluation of the effectiveness of things like exercise, physical therapy, etc. How much does that actually help, not help? Should you be doing it? And then symptomatic treatments, and then disease-modifying treatments. So I'm going to end with this slide. I don't think I have one that's after this. But this is sort of where you need to be in 2015-16, which is probably different than back in 2005, 2006. And so engagement empowers you. So I'm going to just read these. So engagement empowers, so encourage diagnosis, engulf education about dysferlinopathies. That's what you're doing. Employ knowledge to optimize quality of life. This is your chance to be ambassadors because there are a lot of doctors that have no clue what 2B is, let alone limb-girdle muscular dystrophy. So they don't know what these are. You can be the person that helps educate your physician or physicians about this. Enable through community efforts, endow all with your enthusiasm, embolden research, and then the last one, envision no dysferlinopathies. That's me. Thank you very much.